All right, therefore we see this is the slide. What we are discussing today is about 50 MCQs. Comprehensively will cover the immunization in immunocompromised states. We have presented the video, but we will now look at the MCQ, special populations. We have already, we like to go. Newer vaccine technology, dengue vaccination guidelines. Now, the newer vaccines, this will cover only dengue. If we but we would like the others like malaria, streptococcal infection, etc. In the next slide, I will put it up and then we will decide. So we will go ahead with the MCQs. Can you read out the first thing?
Which of the following best describes the general principle regarding live vaccines in immunocompromised children? They are always contraindicated regardless of immune status. They are safer than commonly perceived and can be given in all cases. They pose a higher risk of adverse effects due to uncontrolled replication. They are more immunogenic in immunocompromised hosts.
What do you think is the answer? Lasima, you are there. You can also help. See, they pose see that they are safer than commonly perceived is right. Can be given in all cases is wrong. Cannot be given in all cases. They pose a higher risk of adverse effect due to controlled replication is the right answer. They are contraindicated regardless of the immune status is not right because HIV and all we give initially. They are immunogenic in immunocompromised hosts? No. See, therefore, the answer to that is so the vaccine is high. If you look at the what is given in immunocompromised, can you read what is given in the bracket?
But at the same time,
yeah. Read it.
But at the same time, the immunogenicity or efficacy is lower and the risk of adverse effects with live vaccines is higher. However, vaccination in an immunocompromised child is safer than often perceived.
The safer, but what the answer they gave is what this sentence begins. They safer than commonly perceived can be given in all cases is wrong. That's why that went off this one. Now, can you read this?
In HIV-infected children, when is vaccination usually safe and effective? Only after initiation of antiretroviral therapy, during the symptomatic phase of infection, early in infancy, before severe immune suppression, after CD4 count normalizes.
After CD4 count more than?
No, it is normalization may never occur, you understand. Therefore, it is vaccination usually safe and effective in early infancy before HIV infection causes severe immune suppression. That's the answer. Now, see, these slides, I have put it up. I have told you in a lot of importance because early, the newborn baby, the HIV is infected, that's the time to rush through with the immunization. Similarly, in cirrhosis liver, in adults, they will immunize early because the immunological profile will be better at that time. You want to read the detail? This all we have discussed. You read what is Lasima, can you read it?
Vaccine is usually safe and effective early in infancy before HIV infection causes severe immune suppression.
Okay.
The duration of protection.
That's enough. That's enough. If you start reading everything, we will reach nowhere actually. Okay. Now, read it. One of you can read it. I think Gopika, you read for the first 10, then Lasima will read. Gopika, you read.
Which CD4 plus count or percentage is associated with minimal or no host response to vaccines in HIV infected individuals? CD4 plus less than 500 or less than 25%. CD4 plus cells less than 350 cells per millimeter cube or less than 20. CD4 plus cells less than 200 or less than 15%. Less than 100 or less than 10%.
This may be a tough question because I went through your immunization questions actually. Surprisingly, you see, the whole idea of spending so much time on immunology and immunization is because it's so important from your practicing point of view. Surprisingly, in the DCH questions as well as DNB, I don't find the questions are very much I mean, they have gone into a depth of immunization or something. What's the point in asking a short note on pneumococcal vaccine for DCH students? I don't know. But this is something which you may not know. Do you have an idea? But I put the slides. If you had gone through it, you would have
200.
known it. If you are
Less
appearing for
than two,
me, huh?
less than 200
Yeah, correct.
cells per million.
Generally, a cluster of differentiation less than 200 or 15 known to elicit minimal or no host response. You can read the answer also. Can you read it?
Generally, a cluster of differentiation CD4 plus counts less than 200 cells per millimeter cube or less than 15% is known to elicit minimal or no host response. Even if there is a better antibody response, such an antibody response may wane at a faster rate in HIV-infected
Therefore, when
persons.
the cell count is more than that, naturally you can give. That's what the answer is it not? CD5% has minimal or no host response. Less than 200, you can't give. 15. Above that, you might try to give.
Which of the following live vaccines is specifically excluded from recommendation in asymptomatic HIV-1 infected children by IAP, WHO, AAP, and CDC?
The immunization is in HIV is dependent on symptomatic or asymptomatic. And in asymptomatic, which vaccine is no? I sent you a reminder telling to go through my PowerPoint presentation, which you have not done. Okay, read it.
IAP, WHO recommend all the live vaccines in asymptomatic HIV-infected children except OPV.
So remember this, okay? Remember what is in the bracket, read it.
In IAP, WHO, AAP, Advisory Committee on Immunization Practices, and the Centers for Disease Control and Prevention recommend all the live vaccines in asymptomatic HIV-1 infected children except OPV. However, in a symptomatic child, all live vaccines are forbidden, but at times, measles or MMR or varicella vaccines may be considered on individual merit. Yellow fever vaccine is contraindicated in symptomatic, but can be given in asymptomatic and those at risk of exposure.
Remember this HIV asymptomatic oral polio is contraindicated. All other live vaccine and kill vaccine is allowed. Or symptomatic patients, we will come to later. I mean, it depends on the CD4 count. Therefore, when you give an OPV campaign, we never ask, you understand? The children may know, children with HIV, you might know. Even to the other family members also, if there is another family member who is affected by HIV, you should not be giving HIV to the child who's in the same family. Anyway, normally yellow fever is the one which has more this one. Here, the yellow fever can be given for asymptomatic HIV.
Yes.
Read it. I think the answer is given there. Yeah.
Yellow fever vaccine in HIV-infected children is contraindicated in which group? All HIV-infected children, asymptomatic children, symptomatic children, only those not on ART.
What is it? The previous slide we said we discussed this previous slide. Which one? See, in the previous slide we said yellow fever vaccine is contraindicated in symptomatic, but can be given in asymptomatic. You read it just now. There were symptomatic children. Yellow fever is contraindicated in symptomatic or in asymptomatic exposure. We have read it already. Okay, now we'll go to the next.
What is the recommended action for post-vaccination monitoring in HIV-infected children receiving killed vaccines? Not required as response is always adequate. Seroconversion monitoring is desirable. Only cell-mediated immunity testing is needed. Monitor only if symptomatic. Seroconversion monitoring.
Yeah, seroconversion monitoring for kill vaccine, ideally post-vaccination, seroconversion is required. Anybody else has joined? Nobody? Only you two are there?
Paris is there, sir.
Paris.
Huh?
Paris.
Paris is on duty, isn't it?
Yes, sir.
Okay. What happened to Mohsin? Why is he not joining? Therefore, you can read human immunodeficiency. Now, can you read it?
For kill vaccines in an HIV-infected child, ideally post-vaccination monitoring of seroconversion is desirable.
So most immunosuppressed patients, when you give the vaccination post, seroconversion is desirable. Okay. Read it now. Very practical
A
question.
child A child receiving oral prednisolone 2 mg per kg per day for 3 weeks should receive live virus vaccine immediately after stopping steroids, after discontinuation for at least 1 month, while continuing steroids only if CD4 count is normal.
I emphasize this very much.
After discontinuation or at least.
Quick, which one? A, B, C, or D?
B, sir.
B. Paris undavada. Paris, what's the answer? Not to be seen. Lasima is there?
Sir.
Which is the answer? Okay. Read it.
After discontinuation.
Okay, you read it, Gopika.
Children receiving oral corticosteroids in high doses for more than 2 weeks should not receive live virus vaccine until the steroids have been discontinued for at least 1 month.
Therefore, when you give steroid, there are two things. When you give steroids, during the time you can give, immediately after stopping you can give in some cases, and some cases only after 1 month. Therefore, more than 2 milligram per kg for 2 weeks and more, then you cannot give. This is the first receiving corticosteroid high doses, more than that's what is written for at least 1 month. Now, which of the following
Which of the following corticosteroid regimens allows safe administration of live vaccines during therapy? Prednisolone 2 milligram per kg per day for more than 2 weeks, alternate day therapy, inhaled corticosteroids at high dose, topical steroids with systemic absorption.
This is a question which I was also little it was not there very properly in the slide. Which do you think? Which will you? I understand it's a difficult question. Can you give the answer? Can you can guess? You can make a guess.
Inhaled corticosteroid.
Yeah, see, there's such a discussion is now. Alternate day therapy is what they're effectively given an age-appropriate doses. I didn't find it anywhere in the IAP Purple book, which is given. Maybe the MCQ has picked it up from some other places. But, they say alternate day therapy is the most safer. What is alternate day therapy? There's a single dose early morning once in 48 hours to mimic the circadian rhythm so that it does not what you call depress the hypothalamic axis. But they have written inhaled steroids and topical steroids also are not contraindications. But here they have added a thing, inhaled steroids at high dose and topical steroid with systemic absorption. Looks like they are contraindication to give live vaccine during therapy. I'm not too sure about it. Not sure if the answer is correct. That's what I've written because see here it is. Can you read this?
Children on alternate day therapy, inhaled or topical therapy may be safely and effectively given their age-appropriate vaccines.
Therefore, that is what it is written here. But of course, inhaled steroid at high dose or topical steroid with systemic absorption. They have not discussed about it in IAP book. Maybe in Nelson or some other book it is there. I am not sure. But alternate day therapy is supposed to be very safe. Can you tell?
A
read
child
it?
with
Yeah.
systemic lupus erythematosus on low dose prednisolone, that is less than 20 milligram per day, should never receive live vaccines. Receive live vaccines only after stopping steroids. Can receive live vaccines as low dose, is not immunosuppressive. Receive only inactivated vaccines.
Okay, can you go ahead? See, a child on low dose prednisolone, the systemic lupus erythematosus, there are few conditions in which the patient may be on patient may be on steroids. Therefore, you cannot postpone the immunization forever. Can he receive why on low dose? Yes, the answer is children receiving. Okay, read it.
Children receiving oral corticosteroids in lower doses can receive live vaccines while on therapy. These doses are not immunosuppressive.
Okay, remember that. Less than 2 milligram per kg or 20 milligram. Now we'll go back to the next one and then I'll make the comment. We read what is given in that.
Children receiving oral corticosteroids in lower doses, that is prednisolone less than 2 milligram per kg per day, for those weighing less than 10 kg, or for those weighing more than 10 kg, less than 20 milligram per day, or its equivalent, can receive live vaccines while on therapy. These doses are not immunosuppressive.
That's one thing. Therefore, there are we have said we have discussed this. So I said when I presented it in the slide also, I'm re-emphasizing this very practical point. When you give steroids, see, if the child is receiving steroids 2 milligram per kg, less than in high doses, so for less than 2 weeks can receive the live vaccine after discontinuation of treatment. This is the most important thing which you are doing in asthma. Asthma, you're giving 2 milligram per kg 3 days and then tapering it. You can, after discontinue, you can give any live vaccine. Remember this. If you are giving more than 2 weeks, then of course 1 month you can't give. We know that. Receiving corticosteroid less than 2 milligram per kg can receive live vaccine while on therapy. Remember that also, but we may not have. But what happens is in SLE is he may keep on receiving. And sometimes there will be an alternate day steroids. Therefore, the moment you put him on alternate day steroids, even if you probably can immunize him. But the only problem is something else in SLE. What happens in SLE, the disease itself will call immunosuppression. Therefore, the vaccine may not be effective. Therefore, you will vaccinate Hib, you will vaccinate in double dose. Hepatitis B, you will vaccinate in double dose. In the other vaccine, if there is serology, you can check it. But generally, less than 20 milligram per kg, you can normally vaccinate the children. If I ask you a question, is receiving 30 milligram alternate day? No, 20 milligram per day. Then you can definitely give the vaccination. Okay. Can you read this? Gopika?
Yes, sir. Methotrexate at a dose of less than 0.4 milligram per kg per week in a child is immunosuppressive and contraindicated live vaccine. Requires a 3-month gap before live vaccination. Does not contraindicate any vaccine. Allows only inactivated vaccines.
Such specific questions are not there in your DCH or DNB questions. I don't know if when you appear for NEET exam, these can come up, but these are very practical questions. Many patients are on methotrexate nowadays, rheumatoid arthritis patients. One of the commonest drugs given is methotrexate. The question of immunization will come up. I don't know why they don't give much importance to this. Can you tell me, can you vaccinate or not vaccinate? Of course, in your practical, always have the IAP book with you, the latest edition, open it and then read it. and then say, because it might change.
3-month gap before live vaccination.
No, it's not correct. Read it. Answer.
Children receiving methotrexate at a dose of less than 0.4 milligram per kilogram per week are not immunosuppressed and can receive all vaccines.
This is the one from the IAP book. Same thing, okay? The whole thing, the sentence you read.
Children receiving methotrexate at a dosage of less than 0.4 milligram per kg per week, azathioprine at a dose of less than 3 milligram per kg per day, or 6 mercaptopurine at a dosage of less than 1.5 milligram per kg per day are not immunosuppressed and can receive all vaccines.
It's very important because I think cis mercaptopurine and azathioprine are given in nephrotic syndrome, and the nephrologist may ring you up and ask, can we give? But one of the pediatricians, learned pediatricians, actually, after the last class, he rang me up and said, Padmanabhan, suppose you cannot give. What's the problem in giving one and then checking the serology later? Or if ever you are able to stop these, if you are giving even a higher dose, whenever you are able to stop it again, give a repeat dose rather than not giving at all. That's a question. But they're practically, probably, even if receiving higher dose, you might give, and the vaccine may be wasted. But it may be better than not giving. That is for the practical reason, because side effects are not increased. But generally, remember, less than 0.4 milligram per kg per week. Well, it might be difficult for you to remember the methotrexate dose, the cis mercaptopurine, azathioprine dose. But remember, these drugs definitely not a contraindication straight away. There is a dose. For prednisolone, you should remember, definitely, because in your day-to-day practice, you are giving this. All right. Now, Lysima, can you read it? Lysima also went away, or? Faris, you are there?
Sir, I will read.
Yeah.
Sir.
Who's reading?
Gopika, sir.
Where are you? Nobody else is there. What
Paris ഉണ്ട് പക്ഷേ തിരക്കാണെന്ന് തോന്നുന്നു സർ. ഡ്യൂട്ടിയാണ്.
about Lysima? I don't know how to continue this. Okay, you read it now. Gopika, read it.
For biological response modifying drugs, inactivated vaccine should be administered at least 4 weeks after starting therapy, at least 2 weeks before initiation of therapy, only after 6 months of treatment, concurrently without delay.
Well, it is for splenectomy and all these things. Usually, inactivated vaccine should be given.
At least 2 weeks before.
At least 2 weeks before initiation of biologicals. It's the same as splenectomy also. Live vaccine 4 weeks, I think, you remember. Live vaccine, the next question was on that. Okay, read it.
Live vaccines in children on BRMs should be given anytime during therapy, at least 4 weeks after stopping therapy, at least 4 weeks before initiation of therapy, only if antibody titers are checked.
What is it?
4 weeks before initiation of
therapy. Okay, read it.
Live attenuated vaccines are generally contraindicated during and for weeks to months following discontinuation, should be administered at least 4 weeks before the initiation of therapy.
Now, biological response modifying drugs are being given more and more than before. You know, in rheumatoid arthritis and all, it has produced a tremendous effect. They cause varying degrees of immunosuppression. Now, read what is given in the bracket.
Inactivated.
Can't hear you.
Inactivated vaccines should be preferably administered at least 2 weeks before the initiation of biologics. Live attenuated vaccines are generally contraindicated during and for weeks to months following discontinuation of the BRMs. They should be administered at least 4 weeks before the initiation of therapy.
Influenza vaccine can be given. Okay, next, what's the...
After stopping rituximab therapy, when should re-immunization begin?
Rituximab is supposed to be, is more usually, sometimes is given in chronic ITP. Many conditions, hematological conditions also it is given. It's supposed to be very immunosuppressive. Therefore, there is often asked rituximab therapy. It acts at multiple levels in the immunological cascade. Therefore, what's the answer? Unless you remember it, the answer is, okay.
6 months.
Can you read it?
Once B cell and immunoglobulin levels have recovered, immunization should be recommenced, which is generally 6 months after cessation of rituximab therapy.
Remember, this is a very powerful immunosuppressant. That is why you are 6 months after immunization is when you do after bone marrow transplant or a solid organ transplant, I think, if I am right. And therefore, similarly, rituximab, you do it only that. Now, the whole of the VRM modifying drugs, read it carefully. This can be asked, biological response modifying drugs, immunization in such patients. Can you read it? Cool.
The interval between cessation of the biological response modifying drugs therapy and safe administration of live vaccines has not been established and is likely to vary by agent. Generally, live vaccines may be administered 3 months after cessation of the BRM therapy. However, the recommendations following rituximab therapy is different. Any vaccine history prior to rituximab therapy should be disregarded. Complete re-immunization should be done. Only B cell and immunoglobulin levels have recovered. Immunization should be recommenced, which is generally 6 months after cessation of the rituximab therapy.
Oh, okay. Therefore, this is very important. Biological response modifying drugs usually kill the vaccine. You can, I think, live vaccine you can give only after 3 months. I think kill vaccine can be given after 4 weeks, I think, and not even after 3 months, because it may not produce the response. And for rituximab, it is different. It is 6 months, but before that, you should make sure that he has the B cell and IgG levels have recovered. The others probably you can give after 3 months itself. Why you want to give? Because already there's immunosuppression, and the patient may be more susceptible to infection. As well as rituximab is concerned, it is more dangerous because it knocks off the memory cells completely, and you are very, very susceptible. I don't know whether you are aware of it. Okay.
Infants exposed in utero to maternal BRMs should avoid live vaccines for how long? 3, 6, 9, or 12 months.
Okay. See, this happens because the mother might not be knowing when she started the BRM and biological product, and she becomes pregnant, and she's pregnant, but you have to give her. Should avoid live vaccines for how long? I was also
6 months.
surprised at the huh?
6 months.
Yeah, 6 months, no, 12 months. I was also surprised at it. Okay, read it.
For such infants, live vaccine should be avoided for 12 months after the last maternal dose during pregnancy. Which vaccines should be avoided in infants with in utero BRM exposure in the first year of life? Hepatitis, rotavirus, BCG, ITV. Rotavirus.
It may more likely to be live viral vaccine, is it not? Therefore, actually, there are rotavirus is also oral, viral, but they have written the reference is BCG, OPV, MMR, MR should be avoided in the first year of life. Now you can read in utero expert carefully. Read it now.
Concerns exist regarding immunosuppression in infants exposed in utero to maternally administered BRMs, as detectable drug concentration may be present for many months following delivery. For such infants, live vaccines should be avoided for 12 months after the last maternal dose during pregnancy. BCG, OPV, and MMR or MR should be avoided in the first year of life. The safety of rotavirus vaccines in such infants is debatable and hence may be avoided. All inactivated vaccines should be administered according routine schedule, and immune response during the first few months may be suboptimal depending on the monoclonal used and the gestational period during which it was administered.
Okay, all inactivated vaccines, okay. Even Rota, they are telling it is debatable, but they have put OPV in the avoided. 12 months after that, only you can give live vaccines. Inactivated vaccine, no problem. You can administer according to schedule. Therefore, in this question, the Rota becomes a debatable issue, but definitely BCG is a live vax given only. Therefore, it is definitely more. You see, they say in multiple choice, you should choose the most appropriate answer. Therefore, BCG would be the most appropriate answer. But if I was putting the MCQ, I wouldn't put rotavirus as one of them because both of them look correct to me. Okay, read it.
In children with cancer, the primary cause of immunodeficiency is the malignancy itself, chemotherapy, radiotherapy, malnutrition.
Okay. In a child with ALL, what causes the most important cause of immunodeficiency? Is it the malignancy per self? Is it chemotherapy, radiotherapy, or the malnutrition?
Chemotherapy.
Chemotherapy. Chemotherapy. You are answering, but you are having a lot of doubts about it. In cancer, see, I went through the question. Yeah, I think Lasima has come because his daughter is making. Oh, is your daughter? I don't know.
Yes,
Yeah.
my daughter, sir.
Okay. The malignancy itself is the responsible. Chemotherapy is more important. Okay. That is the important. Now you can read through it. Nobody else has joined or what? Because you will get tired reading this. That's what I am. Anybody else has joined?
Sir.
Lasima is there?
Yes, sir.
No.
Cancer. Yes, sir. I am here.
Okay, read it now because Gopika is tired.
Cancer cases on chemotherapy, radiotherapy. Influence of cancer per se on immune function is minimal and does not contribute to a major extent in inducing an immunocompromised state. Total IG concentration, specific antibody concentrations to already given vaccines are normal at the time of diagnosis, indicating that the effect of cancer on the adaptive immune system is likely to be small. However, chemotherapy for cancer causes major secondary immunodeficiency. The effects of radiotherapy on immune functions are likely to be small in comparison to chemotherapy. Vaccination requirements for cancer cases need special consideration as described below.
Okay, that's very, very important because see, I have found that in the immunization, preventive, that paper in DCA, there's only one question on immunization. And they are normally asking cancer immunization and immunosuppress, immunization, cancer patients, immunization, biological products, they are not asked. So far, I didn't see anywhere. And they're asking, but like surprisingly, preterm, low birth weight, they have never asked. Cancer patients, they are, therefore, these are the general points you should write for a 5-mark answer. Now, next.
Tetanus prophylaxis in a child with cancer on chemotherapy with a dirty wound includes TT booster only, TT plus tetanus immunoglobulin, no prophylaxis needed, only if unimmunized.
Is there a doubt? what's the latent period for? Okay, Gopika, can you answer?
TT plus immunoglobulin.
Yeah, tetanus plus immunoglobulin. All right. Can read this, Lasima?
Tetanus prophylaxis in wound management. In a child with cancer who's on treatment and who then gets a wound. it can assume that the antibody levels are inadequate. So tetanus wound management is as follows. In a clean minor wound, TT booster regardless of immunization status. In all other wounds, TT plus tetanus immunoglobulin.
Okay, self-explanatory. What is this? Okay, read it.
Post-exposure prophylaxis for varicella in a childhood chemotherapy includes MMR vaccine, varicella immunoglobulin or IVIG, oral amantadine, corticosteroids.
Okay. You have a patient with chickenpox. He's exposed to a chickenpox patient. A child who is on a child who is on RCC treatment for acute leukemia. Remember one thing, you pediatricians. Remember, in cancer treatment of leukemia, in cancer patients or many other cancer patients, the patient don't die due to the cancer, but they often die due to infections. They often die due to complications like thrombocytopenia or some other things. Therefore, their life depends equally on the hand of the pediatrician who sees for the first time. Exposed to varicella, it can be a life-threatening thing for a child who has not been given varicella vaccination and does not have a history of varicella. But what will you do for that child? Silence. Gopika, what do you think?
Sir, immunoglobulin can be
Yeah,
given.
varicella immunoglobulin. If it's not available, generalized immunoglobulin therapy. Okay, read it.
Children exposed to varicella should be given prophylaxis with varicella zoster immunoglobulin or IVIG.
Does it ever strike your mind when you have a leukemia patient on treatment to warn him that the best thing is to immunize all other children in the hospital, in the family, and also make sure that he never gets exposed? But if she starts going to school, it will be a problem. Read it. Can you read it? Can you read the whole thing? Yeah.
Children exposed to varicella infection during ongoing chemotherapy should be given prophylaxis with varicella zoster.
Can't hear.
Prophylaxis with varicella zoster immunoglobulin or intravenous immunoglobulin and or oral acyclovir. Under ideal circumstances, varicella immunoglobulin level should be assessed at the time of exposure and for children with less than protective levels. If immunoglobulin should be offered, if doses
Forget the dose.
125
Forget the dose. Read the next sentence.
in case both the above are unaffordable or unavailable, acyclovir 20 mg per kg per dose administered orally 4 times per day with a maximum daily dose of 3,200 milligram or valacyclovir of 20 mg per kg per dose 3 times a day with a maximum daily dose of 3,000 mg beginning 7 days after exposure and continuing for 7 days can be used.
Okay. Therefore, it's an emergency. Please remember this. When a patient with leukemia on treatment or any other malignancy on treatment comes to you and say the younger child or the elder child or the father, mother or somebody in the school had a chickenpox and my child is not immunized. Actually, before they start treatment, they should make sure that the child is immunized, but then the protection may go down over a period of time. That's another thing. Therefore, this is a very important point for you to remember. If you can varicella zoster, if you can do the level, great. If you don't have the level, give varicella zoster immunoglobulin. Not available, give the normal immunoglobulin. Not possible, too costly, at least start acyclovir 7 days after exposure and continue for 7 days. A very practical thing given. Okay.
When can catch-up vaccination begin after stopping chemotherapy in children with cancer? Immediately after 3 months, after 6 months, after 1 year. After 3 months.
1 year.
Okay, read it now.
After 2
So this is your state of affairs after we have presented the video 3 weeks or 4 weeks ago, I think 2 weeks ago or something. I went through all the slides. And I told you yesterday, I sent you the video and told them go through it before you come today. And then now you can go when you go for an exam. Well, you don't have an oral. You are lucky. In our times, MD has an oral. If any of these questions can come up. For DNB, I don't know whether there's oral or not. I'm not sure. Okay, read it. For biology.
Catch vaccination for children.
Yeah.
Catch vaccination for children with cancer should be given 6 months after the stoppage of chemotherapy.
Very good. 6 months after BRM, inactivated vaccine 3 months, live vaccine 6 months, and rituximab after 1 year. Therefore, you should know all this very carefully. Okay. This is the purple book. I said that it is very, all the lines are important. We don't have the time to read it. But anyway, go read what is given in the bracket.
Live vaccines are contraindicated during and for 6 months after the end of chemotherapy. Non-live vaccines are also best given after 6 months from the end of treatment for durable immunity.
Okay. Therefore, cancer management 6 months later vaccine. Bone marrow transplant also, I think it is almost same, 6 months. For biological product, inactivated vaccine 3 months, a live vaccine 6 months, and rituximab after 1 year. Maybe rituximab is also here like this. Now I want you to read this again. The one which is, I want you to stress on this, OPV is contraindicated, including pulse polio doses. Siblings should be continue uninterrupted except for OPV, which needs to be substituted by injectable vaccine. That means if you have a leukemia patient, the siblings should never ever be given OPV, including during pulse polio vaccination. Therefore, whenever a child is given pulse polio, just ask anybody in the family having cancer. And if he's on treatment, don't give him OPV, even if it is pulse polio. This might produce a big problem for you because it's a national campaign. The DMO will be after you. They will bring hell out of you. But tell them in the purple book of IAP, Book of Immunization 2022, it is clearly given OPV is contraindicated, including pulse polio vaccination. Okay. In children, sibling of, okay, this is, all the lines in this are important, but we don't have time to read it. Okay.
Hepatitis B vaccination in an unimmunized cell starting chemotherapy should include standard 3-dose schedule, 4 doses at 0, 1, 2, 12 months at double dose plus immunoglobulin every 3 months. Only hepatitis B immunoglobulin delay until after chemotherapy.
What? Yeah. Yeah, we are very concerned of hepatitis B in patients with cancer because they will be given multiple blood transfusions, they will be given platelets, they will be given RBCs. All these can produce hepatitis B, but we want them to be protected. Therefore, 4 doses, a double dose, we read it now. Can you read? Yeah.
For hepatitis B vaccine, administer 4 doses of vaccine at 0, 1, 2, and 12 months at double dosage. Immunoglobulin every 3 months.
Yeah, you noted hemoglobin every 3 months is fine. 0, 1, 2 is considered accelerated hepatitis B vaccination. Normally 0, 6 weeks, 6 months. You are giving 0, 6 weeks can be given at 4 weeks. Therefore, you are given at 4 weeks early. Then you are giving at 8 weeks. And then you are giving at 12 months. This is called the accelerated hepatitis B vaccination, which the purple book also gives it for hepatitis B mothers, positive mothers, children. One place and does not say it in some other place. Anyway, whatever it is, if you have a patient whom you are going to start chemotherapy, but I don't understand why, if the patient is already having hepatitis, I would rather check the blood level. And if he has hepatitis B antibody more than 10, I would straight away start chemotherapy and give immunoglobulin every 3 months, because it might suppress. Or even if he is positive, you should give this. I am not too sure. But it looks like, we will read it. We'll read the red line below. Purple.
Yeah. For hepatitis B vaccine, in those previously unimmunized and started on chemotherapy, unimmunized and whose hepatitis B surface antigen negative, then it is recommended to administer 4 doses of vaccine at 0, 1, 2, 12 months at double dosage, as well as age appropriate dose of hepatitis B immunoglobulin every 3 months till there is no risk of
Blood products. Therefore, if
exposure
you are
to
sure
blood
no more
products.
blood transfusion or anything will be given, you can stop it. Therefore, this is very clear. Only for hepatitis previously unimmunized. Immunized, you can look at the protective level of antibody. We have a good level, more than 10, I think, international units or something. It is protective, and then you don't have to give it. But here, the unimmunized hepatitis B negative child and whose hepatitis surface antigen negative is already positive, then you don't have to give. Recommend to administer 4 doses. And remember, even that 4 dose is different. It's an accelerated schedule. It is not 0, 6 weeks, 6 months. It is 0, 4 weeks, 8 weeks, and 12 months. And a double dosage, where everything is different. Remember this. Okay, go ahead.
Influenza vaccine in children with cancer should be administered only during chemotherapy annually, starting just before rainy season, only after 1 year post chemotherapy. Not recommended at all.
What is it? You don't know? Read it.
Answer is B. Recommended during ongoing chemotherapy and up to 1 year after completion, just before the onset of the rainy season.
Yeah, influenza vaccine is always given before the influenza winter time in Western countries. For us, is before the rainy season. Therefore, for us, rainy season, I think, is in June. Therefore, you might give at the end of May. Therefore, last year's vaccine only you will get. That's enough for us. Okay. Read what is given in
Annual influenza vaccine is the only vaccine recommended for all children during chemotherapy, whereas hepatitis B vaccine is recommended only for previously unimmunized children with risk of transfusion associated transfusion.
Okay, that we know. Read the last paragraph also.
Sibling immunization should continue uninterrupted except for OPV, which needs to be substituted by injectable vaccine. The influenza vaccine is recommended and varicella vaccine is encouraged for all contacts, including siblings or parents. OPV is contraindicated, including pulse polio doses. Siblings should receive inactivated polio vaccine. If OPV is either given by mistake or given because there is no other option, then the sibling should remain away from the index child for at least 2 weeks.
See how much importance they are giving to it. You understand? OPV is only vaccine contraindicated when biological products are being given. All other live vaccine can be given. Similarly, here, when cancer treatment, in the siblings also OPV should not be given. And if it is given by mistake, they should be away from the patient for at least 2 weeks. Therefore, whenever there's a pulse polio program, don't make a mistake to ask if there is anybody on immunosuppressive treatment at all. Okay. Can you read? As the slide
For
change?
Yeah. Sir, for hematopoietic stem cell transplant recipients, when should inactivated vaccines be given? During conditioning, be at least 2 weeks before conditioning, only after 1 year post-transplant, anytime post-transplant.
Mostly, what is it? This is when should during conditioning, at least 2 weeks before conditioning, 1 week, 1 year post-transplant, anytime post-transplant. Which is the correct answer? Gopika, you are there? She also went away. Huh?
No, sir. Here only.
Okay. Lasima, can you answer? Okay, this is the answer here. Read it.
2 weeks before.
Yeah.
Answer is B. 2 weeks before conditioning should receive all routinely recommended inactivated vaccine at least 2 weeks before the start of the conditioning period.
Usually that is way you are doing a procedure like splenectomy 2 weeks before you should have given the immunization, because we have seen the primary response takes 1 week and may start peaking at about the end of 7 days. Therefore, the second week with 2 weeks you would give a guard time. Live vaccine 4 weeks usually. Okay.
Live vaccine in hematopoietic stem cell transplant recipient should be given during conditioning at least 4 weeks before conditioning, immediately after transplant, only if CD4 plus count is more than 200.
The best answer would be
At least 4 weeks before
Yeah.
conditioning.
Okay, read it.
Routinely recommended live virus vaccines should be administered if the patient is not already immunosuppressed and the interval to the start of the conditioning period is at least 4 weeks. After hematopoietic stem cell transplantation, recipients are considered fully immunized, like unimmunized individuals, immune for 6 months, protected by maternal antibodies. Like unimmunized individuals.
Very good, like unimmunized individuals. In fact, one of my colleagues is actually nationally famous pathologist. He underwent hematopoietic stem cell transplantation for multiple myeloma. When I read this, I rang up to him and asked him what are the vaccination he's given. And he was surprised by some things which I sent it to him, actually. Therefore, don't take for granted whenever a child with a bone marrow transplant comes, they say that we have followed whatever RCC has said, must go through it before you, okay? All memory cells bone marrow ablation. Therefore, same is for rituximab therapy also. The same is for hematopoietic stem cell therapy. But splenectomy, all live vaccines, there's not so much of a problem, really. Okay, read it. Read the whole thing.
The patients for whom hematopoietic stem cell transplant is planned should receive all routinely recommended inactivated vaccines, including the influenza vaccine, at least 2 weeks before the start of the conditioning period, when possible. Routinely recommended live virus vaccines should be administered if the patient is not already immunosuppressed, and the interval to the start of the conditioning period is at least 4 weeks. By vaccinating the non-immune patient before HSCT, some protection likely will persist in the months after transplant. However, recipients of hematopoietic stem cell transplantation are like the unimmunized, as they have lost all memory responses during marrow ablation.
What do you mean by conditioning therapy? It's not 2 weeks before the bone marrow transplant. Remember that. 2 weeks before the conditioning therapy. What is conditioning therapy? They start giving medicines which will knock off the bone marrow of the patient. You understand? They're put in a period like a bubble. They don't allow anybody inside. Even the nurses, I think, are not allowed inside. And during that inactivity, they give medicines so that completely the bone marrow is gone. That's called the conditioning therapy. Therefore, after then they look at the immunological profile. When all the bone marrow is completely dropped down, only they will give through the IV, the bone marrow of the donor. For conditioning therapy, before 2 weeks before conditioning therapy, not the bone marrow transplant. Okay. Can you read
Solid
it?
organ transplant recipients receive lifelong antibiotics, antivirals, immunosuppression, corticosteroids only.
Immunosuppression.
Immunosuppression.
Immunosuppression is yes to be okay. Reference solid organ lifelong immunosuppression. This is the last one. Generally, this is the problem because they receive lifelong immunosuppression. The degree of immune is the greatest in the first 3 to 6 months of transplant. That's the only thing. Okay, now.
The pre-transplant vaccinations with inactivated vaccines should be completed at least 1 week before transplant, 2 weeks before transplant, 4 weeks on the day of transplant.
Well, we thought that for this, what you call hematopoietic cell and all live vaccine 4 weeks and the other one 2 weeks. Here it seems, and I think splenectomy also, it is 2 weeks. Therefore, 2 weeks before transplant is the 2 weeks before the schedule. All right, that's the right answer.
MMR vaccine in infants 6 to 11 months awaiting transplant can be given if transplant is delayed beyond 12 months, transplant is expected before 12 months, CD4 count is more than 500, no contraindication exists.
What is it? See, the youngest age at which MMR vaccine can be given is 6 months in 2 situations. 1, when there's an epidemic. 2, if the patient is waiting and you're going to do a kidney transplant at 8 months or 9-month-old child, you can give it at 6 months, but you have to repeat the dose. If you are giving during an epidemic, you have to repeat the dose. Anyway, okay, read it now.
Vaccination schedule with inactivated vaccines should be completed at least 2 weeks before the scheduled transplant.
Okay. You can read the whole thing.
Vaccination schedules with inactivated vaccines should be completed at least 2 weeks before the scheduled transplant.
This
Vaccination
is
with
pre-solid
live
organ
vaccines.
transplantation, before the transplantation. Post will come later. Okay.
Vaccination with live vaccines should be completed at least 4 weeks prior to transplant. MMR and varicella vaccine may be given to infants 6 to 11 months of age if transplantation is expected to occur before age 12 months. And if transplantation is delayed, repeat doses should be given starting at 1 year of age. It is desirable that seroconversion be documented.
Here, see here, this is the problem here. This question is, there's a mistake in 26 question, is it not? Pre-transplant vaccine inactivated. Here they have asked inactivated, therefore it's right, 2 weeks. Live vaccine is 4 weeks, okay? That's right, they are right. Okay, now we come to the post. So suppose a patient has got a solid organ transplantation. When can you give inactivated vaccine?
Post solid organ vaccination with inactivated vaccine is best started at least 6 months post transplant.
Yeah, first 6 months. 6 months post-transplant, you are right. Next.
Annual influenza vaccination post solid organ transplantation is not recommended, optional, contraindicated.
Recommended.
Recommended for how long after the transplant? You lifelong or? Annual influenza vaccine is recommended. Actually, it is better to give, I think it's 1 year anyway. This one?
Live vaccines post solid organ transplant are always safe, generally contraindicated, recommended at 3 months, given with steroids.
You are given a solid organ transplant. That means you are given a chronic renal failure or something. You are then an organ. Will you give live vaccines?
Contraindicated.
Yeah. If I think this something is different, is it not? That live vaccines are contraindicated in post-transplant period, where while a hematological transplant, all others conditions, immunosuppression, you do give after 6 months. Here, I think it is because the live vaccines may, if the patient is already on immunosuppressive medicines, and it may, therefore, is already immunosuppressed. And you know that a solid organ transplant patient, unlike a bone marrow transplant, after 3 or 4 months, all drugs are stopped. Splenectomy, all drugs are stopped. HIV depends on the immunological status of the patient. But SOT, the patient is on immunosuppressive treatment. That is why probably it is not given. Now you can read it. Maybe you can read all that is in the bracket. Read it.
Post-solid organ transplantation. Inactivated vaccines are safe in the post-transplant period. However, they are best administered at least 6 months post-transplant to elicit an optimal immune response in patients where immunization has not been completed prior to transplant. Vaccination with inactivated vaccines can recommence 6 months post-transplant when immunosuppression has been lowered. Annual influenza vaccine is recommended. Generally, all live vaccines are contraindicated in the post-transplant period. However, recent studies shows that the live vaccines may be administered at least 1 year after transplant and when the degree of immunosuppression is very low.
Post-organ transplant, they made a sentence like that also. That's why it's not simple. You will get confused in this actually. When you get a referral asking you what to do, it's better to read the latest, what is given, the purple book. The first it was the pink book, now it's a purple. It may turn to yellow next year after 3 years. You actually it is given well in the immunization IAP book chapter, but in some other place they may give something else also. Therefore, go by this book preferably for these advice. Now we come to spleen.
Children with asplenia are at high risk of infections with gram-negative rods, encapsulated organism, mycobacteria, fungi.
This you should know. Very good.
Encapsulated.
Encapsulated. That's why you are very concerned about giving pneumococcal vaccine, PCV 23 to pneumococcal PP, polysaccharide vaccine to 23 to these patients. Okay, read it. Children with asplenia,
Children with asplenia or hyposplenia are at high risk of serious infections with encapsulated organisms.
Okay. Can you read it?
Vaccination before elective splenectomy should be completed at least 24 hours prior, 1 week prior, 2 weeks prior on the day of surgery.
24 hours.
Patient is going to undergo splenectomy, say for congenital spherocytosis or some other reason. Very rare, the splenectomy prevail, but if he is going to be done for a splenic rupture, you can't do anything.
2 weeks.
But if you have a time interval, you can ask the surgeon to postpone the surgery. How long before, after giving the vaccine?
2 weeks.
2 weeks, yeah, we said that already. 2 weeks prior to vaccination.
Which of the following live vaccines is safe in asplenic children? OPV, BCG, MMR, all live vaccines may be safely given.
See, in spleen, only the lymph nodes of the spleen are removed. The bone marrow, it is there. The liver, it is there. Lymph nodes are there. If all live vaccine can be safely given. Remember, this is very important. You must know what is the criteria in splenectomy patient, what's the criteria in home bone marrow transplant patient, what's the criteria in solid organ transplant patient, what's the transplant in congenital immunodeficiency, what's the criteria for HIV patients. All are different. Okay. All live vaccines can be given to spleen. Remember this way, that the lymph nodes are not situated only in the spleen, is situated everywhere. Okay, read the full thing.
Asplenia or hyposplenia. Asplenia or hyposplenia may result from sickle cell disease or radiation therapy involving the spleen. Children with asplenia or hyposplenia are at high risk of serious infections with encapsulated organisms. Vaccination with pneumococcal, both conjugate and polysaccharide, hip conjugate vaccine, meningococcal conjugate vaccine, and typhoid conjugate vaccine is indicated in addition to all routine vaccines. In patients with planned splenectomy, vaccination schedule should be completed at least 2 weeks prior to splenectomy for achieving a superior immunological response. In those who have undergone emergency splenectomy, studies indicate that vaccination done 2 weeks after splenectomy is associated with a superior functional antibody response as compared to vaccination immediately following surgery. However, vaccination can be initiated at the time of discharge. All live vaccines may be safely given.
Remember this very carefully. Asplenia patients are not that immunocompromised. Only their problem is with encapsulated organism like pneumococci, meningococci, hip type. Therefore, these patients should receive these vaccines at least 2 weeks prior to splenectomy. And post also 2 weeks is enough. There's no need to wait for 6 months or 3 months, unlike. And remember, all live vaccine can be given safely. Therefore, splenectomy is not like other immunosuppressed patients. Okay, now.
Children with chronic diseases like diabetes or heart diseases should receive only inactivated vaccine, no vaccines, pneumococcal and influenza vaccine, only BCG.
Pneumococcal and influenza.
Yeah, maybe I don't know why they gave offer pneumococcal, hepatitis A, varicella, influenza, rotavirus. I don't understand this because you have to give all vaccination to all these patients, and these children with chronic diseases. Read the sentence. They are written here that these children should be offered pneumococcal.
These children should be offered pneumococcal, hepatitis A, varicella, influenza, and rotavirus vaccines. The immunogenicity, efficacy, and duration of protection of vaccines are lower than healthy children and hence indicated higher antigen content or more doses, as in hepatitis B.
Other than hepatitis B, I don't think you can give a higher antigen dose anything. This looks a little vague to me because chronic diseases, he would have already been immunized. Do you want to give another immunization? I'm not too sure. Maybe meningococcal vaccine, what is not advised in the national program. The other vaccines also you continue, like flu, hepatitis A, varicella, rotavirus, you can't give above 8 months or something. Therefore, all this is very important for us. Okay. I think Rota, they now say up to 2 years, I think. I'm not too sure about it. Okay. I think it's 2 years. WHO has said up to 2 years. Okay.
Egg allergic children with history of anaphylaxis can receive
Can you see?
None of the above.
influenza vaccine.
None of the above.
History of anaphylaxis, they have not written what is that history to. You understand? And I don't know. Well, let's see what it is. Given B, children with previous anaphylaxis to egg can receive. See, egg allergic patient. I'm sorry, I forgot that egg allergy is not a contraindication to receive influenza vaccine in a center where staff is treating anaphylactic reaction. Okay. Egg allergic children history of anaphylaxis. That means if you take egg and you just develop rashes, it's not an allergy at all. But about yellow fever and MMR, I'm not too sure. MMR vaccine is also correct. Actually, that's what I said. MMR, we will come to that in the later chapter. Actually, this is a very important thing. Many mothers will come and say, Dr. Mutta കഴിക്കുമ്പോൾ when he eats egg, a lot of rashes come. And there are patients who come and say that he starts coughing and he becomes dyspneic also. Therefore, can we give MMR? MMR does chick embryo, it is grown. Therefore, there is a doubt whether it can be given. Generally, it is said it can be given. And yellow fever is one thing. Therefore, let's go and read the next slide, please. Read what is given in the bracket.
Children with a history of serious egg allergy should not receive yellow fever vaccines, but can safely receive other vaccines, including measles and MMR vaccines. Children with a history of egg allergy who have experienced only hives after exposure to egg should receive any influenza vaccine, inactivated, recombinant, or live attenuated, without specific precautions, except a 15-minute observation period. Children with previous anaphylaxis to egg can receive the influenza vaccine in a center where staff experienced in recognizing and treating anaphylactic reactions are available, and the child should be under observation for a minimum of 1 hour.
See, let's be very clear. I have put up 2 videos regarding anaphylaxis. I'll give the link to its own. You should see it. I will put only the MCQs about it. I am not going to repeat it because anaphylaxis is a very, very important thing as far as you and I are concerned. Because once you say you gave a vaccine and the patient produced anaphylaxis, it is lifelong contraindication to the vaccine. Remember this. Now we are giving hexavalent vaccine, pentavalent vaccine. If you develop an anaphylaxis after that, the patient cannot receive all the 5 doses, all the 6 vaccines lifelong. Here it is something different. It's an egg allergy they are asking. Egg allergy, if there is, forget rashes, they can take anything. But if it is a history of serious egg allergy, what they mean by serious is it required admission. That's what, or it was definite, it fulfilled the criteria of anaphylaxis, yellow fever cannot be given. But what about influenza vaccine? If you have just received hives, you can give it. But if it is, again, anaphylaxis to egg, you should be ready for treatment of anaphylaxis. Better that you don't give in PRS. You send him to SAT hospital. They will also probably not give it. Why give him influenza vaccine to this patient? But the more important question is whether you can give MMR. Now, this is clear. This question will come to you in your examination. Tell them if there is simply rashes, you can give. Even anaphylaxis to egg, as per the purple book, you can give. Read this sentence very carefully. Children with a history of serious egg allergy should not receive yellow fever vaccine, but can safely receive other vaccine, including measles and MMR vaccine. Remember this carefully. Therefore, it's not a contraindication. Now we will be discussing adverse reaction. That's a very important to vaccine, which will be classified as many things. And this is MMR vaccine. Egg allergy is not a contraindication. Yellow fever is a contraindication if it is anaphylaxis history. And what about this? Anyway, now let's. I think it's over. Okay, read the first sentence, please.
Children who have had a serious hypersensitivity reaction or anaphylaxis to a particular vaccine must never receive it again. A mild reaction is not a contraindication to vaccination.
Remember this, if you have written in the case sheet that this child I gave pentavalent, he developed anaphylaxis and I gave adrenaline, probably nobody will immunize the child again. That's what will happen. Therefore, the decision of a pediatrician to say whether there is, whatever reaction is a vasovagal syncope or hypotonic, hyporesponsive effect, these are relative contraindication. Once you have labeled it as anaphylaxis, lifelong the child cannot receive any one of them. And therefore, you should know the definition of anaphylaxis pinpoint is not a small thing. When there is doubt of anaphylaxis, you will have to treat him with adrenaline. It's life-saving. But unnecessarily you give adrenaline or you diagnose this anaphylaxis, that will also create a huge problem. That's why I think pediatricians should be fully aware of what anaphylaxis is. And actually, I've gone and met many classes in which, in fact, the latest in the KIMS held a meeting on allergic emergencies, and there was a talk by anaphylaxis. Many things which are very important was never emphasized. Okay, and we'll come to that in a later time. Now, What is this?
Yellow fever vaccine in breastfeeding mothers is safe, should be avoided due to risk of infantile meningoencephalitis, can be given with dose adjustment, requires stopping breastfeeding for 3 days.
What do you say? May I ask you, Gobia, you have been here for 2 years now, more than 2 years, I think. Has any class been taken on breastfeeding? Yes or no? Hello?
No, sir.
What's it? Who's answering?
Yes, sir. Yes, sir. Sir had taken a class on breastfeeding when
Who?
I joined
Who took? Which sir?
you, sir.
Huh? I took
Sir, we had present. Yes, sir. We had presented from Elizabeth Madam's book.
breastfeeding. Yeah,
That
okay.
is comparison of breastfeeding. I mean, breast milk and cow's milk and all. One
Okay.
class was there when Rose Doctor was also there.
Okay, this is Gopika talking or who's talking?
Yes, sir. Gopika.
Okay. The Lasima is there, you have taken? Remember, breastfeeding is a very important thing. I have gone through the DCH question papers.
No,
They are
sir.
more tuned towards national programs, more tuned towards what you call social pediatrics. Remember this. Therefore, breastfeeding is a very, very important topic. And you better ask Anju Deepak if she has breastfeeding. She might be having slides. I will talk to her also. If she has slides, if she can take the latest presentation and teach you. Well, if I ask you a simple, straightforward question, what is a contraindication for breastfeeding in children in a newborn?
Chemotherapy, receiving chemotherapy,
Tuberculosis.
mother
Okay,
receiving
chemotherapy. Okay, any other medicine?
If the mother is having tuberculosis but not taking ART,
Yeah, it cannot be,
APT,
is it not? She should take ART, and that cannot be said as a contraindication. Maternal psychosis is supposed to be the other contraindication. Any other medicine? Because most of the medicine you give, chemotherapy, usually the mother will not become pregnant. And even if she is pregnant, maybe if she delivers, she may not have milk. Anyway, chemotherapy, you can say, if the mother is on chemotherapy, there's no question of feeding the child. Now, suppose any
no other
other
drugs are
medication you
contraindicated.
can think of.
antithyroid drugs.
Very good. Anti-thyroid drugs. Methimazole and propylthiouracil also, I'm not too sure. One of them is a contraindication. Methicarbamazole or something is a contraindication.
Carbamazole.
That's the one which the mother might be taking because you can get pregnant on anti-thyroid drugs. The other is, of course, the answer is maternal psychosis, not maternal depression. Postpartum blues are not a contraindication. Maternal psychosis is generally considered as a contraindication. Now, thou intensive therapy, they say you can breastfeed. Now, here's a question in breastfeeding mothers. I was surprised at the answer. Look at the answer. Yellow fever in breastfeeding mothers should be avoided due to risk of infantile meningoencephalitis. Read it. Read the answer, please.
The transmission of the yellow fever vaccine virus through breast milk and resulting in infantile meningoencephalitis has been described.
Immunization and lactation. The only exception is, read it, yeah.
The only exception to live vaccine use is the yellow fever vaccine. Transmission of the yellow fever vaccine virus through breast milk and resulting in infantile meningoencephalitis has been described.
Okay, now the next thing is also, therefore, hence, if yellow fever should be yellow vaccine should be avoided in breastfeeding mothers. If mandatory, breastfeeding should be interrupted for a 10-day post-vaccination viremic period. Okay, this is very, I didn't know about it. A little surprised. Yellow fever, you cannot give. Remember, in patients with um, who are immunosuppressed, you can still, with what you call biological products, I think you can still give yellow fever, but not OPV. But at the same time, in lactation, you can't give yellow fever vaccine to the mother. And if you are forced to give, see, this will happen only if the mother comes and says, my husband is in Africa, I'm going there. To the yellow fever has got a funny thing. You know, the virus, many people travel between Africa and India. The conditions are very good for having yellow fever epidemics in India. The mosquito is the same as Zika virus or other viruses. It is there. It is there in India, but still there's no yellow fever in India, luckily. Therefore, we don't want it to be imported. Therefore, if a mother says, I want to go, I have to take yellow fever, otherwise I won't get clearance. If he's lactating, then after the vaccination, she cannot feed for 10 days. Remember this. Okay. Now coming to special situation, preterm and low birth weight.
Hepatitis B vaccine in preterm infants less than 2 kg born to HBsAg negative mothers should be given at birth, delayed until 1 month or discharge, not given with HBIG.
What's it?
Given at birth.
Preterm babies less than HBsAg negative mothers.
Delayed until
Given at
less than 2 kg.
My God, what is happening to HBAG negative mothers in the SCABU in your place? See, these knowledge everybody should have, including the nurse, including the doctors, including the junior most house surgeon there. Because then only mistakes will not be made. Because sometimes a consultant might just say, give it, or don't give it. Therefore, everybody should think inside a ward in the rounds. It's not that you just blindly follow the consultant's order. Why I'm telling you this is, I know when I take my rounds, I have moments at which your memory, you will think of something else and order something else. Now, hepatitis B below is 1.5 kg. Do you immunize the child immediately? Hepatitis B is the birth dose given. OPV given, 1.5 kg. I've been asking you this 100 times. In your own, Lasima, when you were there in the SCABU, a baby is born 1.5 kg. Is he given BCG at birth? I'm not asking what is given in the purple book. I'm asking, is it given in a hospital?
no, sir.
Is OPV given?
No.
Is hepatitis B given?
No, sir.
Then why you said within 24 hours, given at birth? All right.
Ideally, we have to give.
Ideally, you have to give for hepatitis B mother at birth. Okay. Remember, every vaccine has to be given as per chronological order, except hepatitis B. I don't know why you didn't get it when I taught you. Read it. Can you read it? Answer.
Infants weighing less than 2 kg born to HBsAg negative mother should receive the first dose at chronological age 1 month or hospital discharge.
Okay. Hospital discharge, they say even if the child is not chronologically 1 month, you should give. But I'm not too sure about it anyway. Now read this. We'll come to the discussion later. Okay.
Birth dose of hepatitis B in preterm less than 2 kg born to HBsAg positive mothers should be delayed, given with HBIG within 12 hours, not given at 1 month. Given with HBIG within 12 hours.
Yeah, we know below 2 kg, the HBsAg is not that effective, but you cannot delay it in a mother who's HBsAg positive. Okay, that's the right thing. That's the answer. Anyway, that's the answer.
In
now
babies less than 2 kg born to...
Yeah, read it then. In babies less than 2 kg.
Born to a hepatitis B positive mother, hepatitis B vaccine should be given along with HBIG within 12 hours of birth.
I think immunization or preterm, you read the whole thing. Somehow or the other, you don't seem to understand what's going on. Okay, read it whole thing fast.
Immunization in preterm or low birth weight infants. In principle, all vaccines may be administered as per schedule according to the chronological age, irrespective of birth weight or period of gestation. BCG and birth dose of OPV can be safely and effectively given to low birth weight and preterm babies after stabilization and preferably at the time of discharge. Studies have shown that the take of BCG, as assessed by induration following the Mando test and lymphocyte migration inhibition test, is similar in preterm or low birth weight babies, whether given at discharge or later. The birth dose of hepatitis B vaccine can be administered at any time after birth in babies weighing 2 kg. However, in babies less than 2 kg, the immunogenicity of the birth dose of the vaccine has been shown to be suboptimal in some studies. Hence, the birth dose of hepatitis B vaccine in these babies should be delayed until the age of 1 month. Alternatively, these babies may also be given the first dose of the vaccine at the time of discharge if consistent weight gain is achieved.
Now, this is what this is what I say that the purple book fails you in many things. See, they say in principle, all vaccines should be administered according to chronological age. Irrespective, chronological age means what? A child of 1 kg is born, 0 dose should be given at that time. Is it not? Am I right? Next sentence, what they say, BCG and birth dose can be safely and effectively given to low birth and preterm babies after stabilization. Okay. And preferably at the time of discharge. What does this mean? See, the time of discharge for a preterm baby may be months after he is born. How can that be same as chronological age? This is how they can be very, very vague and stupid at times in the immunization book. There should be no difference in it. Here also, the birth dose should be delayed until the age of 1 month. Can be given the first dose of vaccine time of discharge. Therefore, if a baby you are discharging 1.4, 1.3, 1.5, you are sure the baby will come back for immunization at 2 kg. Why don't you delay it? Therefore, should you give it at birth? Hepatitis B mothers who are negative, hepatitis B negative mothers, child is less than 2 kg, better to give it at 1 month. For practical reasons, you may give it at time of discharge, even if he is not 1 month old. BCG and OPV as per chronological age. That also you can say in most of our hospitals, we are giving at the time of discharge. Now here, you are not the only person to be compromised. Hepatitis B management of preterm babies less than 2 kg. Now this is hepatitis B vaccine in page 150 of the purple book. What they say is, if the mother is positive, okay, you have given at birth 2 doses, administer 3 additional doses of hepatitis B at 6, 10, and 14 weeks. This is a normal thing. Okay, normally you give that. There's nothing else he has written. Test for SBAG antibody 1 to 2 months after completion of 3 doses. Actually, you should test at 9 months. Testing should not be performed before 9 months. See, what nonsense has he written? If he has says that test for 1 to 2 months to SBSAG, the last dose is given at 14 weeks, it will come to 5 or 6 months. And then he says, don't test before 9 months. No, within 4 weeks of the most recent vaccine. Normally, what is given is you are giving the birth dose earlier. You are 6, 10, and 14 only. He has not written 0 dose here. Now come here. This is in this hepatitis B vaccine schedule. The mother is positive is this. Mother is negative. A hepatitis B vaccine can be given to low birth weight and premature infants. For these infants, the birth dose should not be counted. He has given something different. Should we give it if the baby is less than 2 kg? Here is less than 2 kg. Can be given to low birth weight and premature infants. When? He has not given it. Now let's go a little further and say what is happening. This is immunization. This is the same book, 4.2, immunization special situation in page 466. You can read what is given in that. Can you read it, Doctor? I'm going slow here because you must know what is right. Gopika, can you read it?
In babies less than 2 kg born to a hepatitis B positive mother, hepatitis B vaccine should be given along with HBIG within 12 hours of birth, and 3 more doses at 1, 2, and 6 months are recommended.
Wait
Since
here a minute.
most
Wait here a
develop-
minute, Gopika. See this very carefully. Should be given 12 hours at we gave at birth. 3 doses at 1 month. Normally we give 6 weeks. He's giving it 4 weeks. And then you give only at 6 months. Here he is giving it 2 months also. Okay, therefore total 4 doses he is recommending at an accelerated response. Baby's hepatitis B, but he has not written double dose or anything like that. Remember that in patients with we have said that patients on cancer treatment or patients where a mother is given biological products, they have written 1, 2, and 12 months. Here they have written 6 months are recommended. Okay, fine. Hepatitis B vaccine at birth, there only 4 doses are indicated. Anyway, we give these 3 doses. And we give a 0 dose. Therefore, there's no additional dose that is given. Okay, now read the rest.
Since most developing countries employ the UPI schedule of 6, 10, 14 weeks with a pentavalent or hexavalent vaccine containing the hepatitis B antigen, in 2017, the WHO recommended that a birth dose of hepatitis B vaccine can be given to low birth weight and premature infants. For these infants, the birth dose should not count as part of the primary 3-dose series. The 3 doses of the standard primary series should be given according to the national vaccination schedule.
I don't understand this because even for normal children, we give a birth dose, okay? And then we give 3 primary doses, 6, 10, and 14. We are giving a national immunization program. We are giving in the IAP is also advising it. What does this mean? Should not be counted. And then he says 3 doses are given. This is the normal immunization schedule. Only thing he is giving is hepatitis in 2000, WHO recommend that the birth dose hepatitis be given at low birth weight infant. When? He has not written when. You understand? Should you give it at the time of birth or should you give it when the time patient is 1 month? It's not clear. Okay? This is how they can be vague. But remember that CDC and immunization, special situation, special healthcare, what have they written? Can you read the yellow line? Yellow.
Infants weighing less than 2 kg born to HPCG negative mothers should receive the first dose of hepatitis B vaccine series at chronological age 1 month or hospital discharge. If hospital discharge occurs when the infant is younger than 1 month of age.
Remember this. Therefore, birth dose they are telling is not right. If a baby is less than 2 kg, and the mother is hepatitis A negative, the mother, we are doing the screening. You are not supposed to give the vaccination at that time. Okay. The WHO says the birth dose can be given, but it is not that effective. Why you want to give? This is a big problem because why I'm stressing this is one of my colleagues who is a pediatrician in a hospital in Middle Travancore, which has about 200 deliveries per month, and he's a well-known pediatrician, a neonatologist. He says that he was not giving below 2 kg. And then the health worker from the DMO office called him and said, why you are not giving? He said, this is the evidence. He said, no, it's a national program. You should give it at birth. That's what the WHO says. He said, I cannot give. Then they said, the problem is that hepatitis B vaccine, monovalent vaccine was not available in the public. There was a short supply. Therefore, you have to get it from DMO office. The DMO office said, we will not give you the vaccine then. Therefore, he was forced to give to hepatitis negative mothers whose weight was 1.5, even 800 grams, because the government wants to show that they are giving the birth dose at birth. Therefore, remember here, There's a huge problem. Employ the UPI Schedule 60 with the 2017 WHO recommend the birth dose hepatitis can be given to low birth weight. Yes, it can be given. But at what age he has not written. Is the birth dose at 0? It's not clear. Now it will come clear as we go ahead also. Can you same this?
Rotavirus vaccine in preterm infant should be given at birth, deferred until discharge, give only if term avoided.
What is it? You are not reading. Rotavirus should be deferred until discharge from the hospital because it might spread from one child to the other. Same was told about OPV also. I told you this, that in Espajan, in fact, it says if the patient is in NICU, never give OPV because it can spread inside this. But now that is not told in India because we want to give the birth dose. Now, rotavirus should be deferred according to them. Remember, immunization preterm, read this, what is given in the bracket.
Rotavirus vaccine, which should be deferred until discharge from the hospital to prevent the potential healthcare associated spread of this live vaccine virus and has acceptable safety, immunogenicity, and efficacy.
Should be deferred until discharge to prevent the potential healthcare associated spread of this live vaccine inside the nursery. Same thing is told about OPV also, if I remember rightly, by the Espajan. And the American Academy of Pediatrics doesn't open his mouth because they don't give polio at all, oral polio at all. Okay. Okay, now I want to tell you one thing. Be very clear about newborn vaccination. Mother is hepatitis B negative. The only vaccine which is problematic not to give chronological order is hepatitis B vaccine. If you are giving hepatitis B, if the mother is negative, better postpone it to 1 month. Positive, we know what to do. Now, you are not supposed to what you call count the birth dose, and then they say give 6, 10, and 14 weeks, which we are already doing. We are giving 4 doses for everybody. But the only thing is, if the mother is positive, I would like to ask, this is a postgraduate question actually. The mother is positive for hepatitis B, and the gynecologist is very concerned about it, or else the mother herself is a doctor. What is the best option available to her? Gopika, can you tell?
Both hepatitis B vaccine and immunoglobulin.
You give hepatitis B vaccine and immunoglobulin immediately. Say it's a full term baby, you give full term, and then you give what are the doses you give. When do you give that vaccine? Some books do say 6, 10, and 14 weeks. That is enough. Some would say 0, 1 month, 2 months, 6 months, because there's an accelerated response here. And then what? Is there any difference? Gopika, is there any difference in the subsequent action? Mother is hepatitis B positive.
Booster doses.
Okay, then subsequently you have to do anything?
Booster doses at 12 months.
No. At
Sir,
9
HBS
months,
level should
at
be
9 months, you
anti-HBS.
should test the hepatitis B status of the child, because you are given hepatitis B and immunoglobulin together at birth. The immunoglobulin would have prevented the 0 conversion. Therefore, you will have to do the hepatitis B antibody level at 9 months. If his antibody is positive, that means either he has got infected or he is immune. And you have to do nothing. If the antibody level comes negative, you have to re-immunize the patient with again 0, 6 weeks, 6 months, sometimes with double dose. That's it. Now you do it twice, and the patient is again hepatitis B negative. What will you do? Then you don't give a third dose. Your third schedule is not done. Twice, you will repeat it once, no more schedule. If there's a health worker, suppose you have a health worker who is hepatitis B negative, you immunize him twice. He doesn't become poly. There are certain patients who don't have a zero conversion. What you do for these patients is lifelong hepatitis B immunoglobulin whenever they are exposed to blood or have a needle prick. That's the only way forward for them. Well, okay, read it.
Subunit vaccines are made from whole the pathogen, live attenuated pathogen, a piece of pathogen, mRNA of the pathogen.
Subunit vaccine is what? Classical subunit vaccine is hepatitis B. It's a subunit vaccine. Okay, read it.
Subunit vaccines are made from a piece of a pathogen, not the whole organ.
Now we are going into vaccination. From immunosuppression, we are going into newer vaccines. And we will be discussing, if possible, only dengue vaccine today. And already only 9 minutes are preparing, therefore I'm not sure. Now this is what is, I would just show you what it is. Now this is, see, this is subunit recombinant polysaccharide. Subunit vaccine as a portion of the bacteria virus that can cause an immune response independent of its virus origin. Elements of subunit vaccine can be protein, polysaccharide, or combination. Viral proteins are isolated in lab, mixed with an adjuvant immune system, and injected into the body to cause an immune response. The human body and it adjuvant, the antigen presenting cell takes the protein, is taken up by the antigen displayed on the surface, and the antigen is presented and the threat is detected. Therefore, only a portion. Subunit vaccines are made from a piece of the pathogen, not the whole organ. So therefore, they are not live vaccine, they are kill vaccine. Classical example is hepatitis B. Many other vaccines, typhoid, etc., they also manufacture subunit. But I think the one which is available mostly a conjugated vaccine. And now we come to a technology called reverse vaccinology. Can you say what it's?
Reverse vaccinology was first successfully used for COVID, dengue, group B, meningococcus, hepatitis B.
What's the answer?
Dengue.
Reverse vaccinology results in successful vaccines against group B meningococcal vaccine. Now, I have told this is a little difficult to understand. I don't think they will ask you at this level, but they keep on asking future vaccines like that, newer vaccines. So when you are asked newer vaccines, the vaccines which are available in the market are not newer vaccines. The newer vaccines would be dengue, would be malaria, which is just coming, vaccines and streptococcal vaccines, and vaccines against cancer, etc. Not the human papilloma virus vaccine, which is an old vaccine. Now, one of the they use is they have used new techniques. Before, how was the vaccine made? You kill the vaccine, make it attenuated and injected. That's how, therefore, the antibody is produced. Now, the whole thing has changed. There's something called reverse vaccinology. You read it now carefully. It's not easy to understand. You read it.
Reverse vaccinology is defined as an innovative approach to vaccine development that utilizes bioinformatics and computational analysis to identify potential vaccine targets within pathogen genomes, allowing for the modeling of epitopes and the creation of a tailored vaccine for improved efficacy and safety. Reverse vaccinology is a new approach to designing vaccines that combines our rapidly increasing feasibility to sequence a whole genome of microorganism and apply bioinformatic analysis to those data. Predictive modeling identifies new pathogen targets that are ideally conserved and targets of protective responses. The subsequent expression of candidate targets for screening by using the human serum from those with effective immunity and for evaluation in murine models can lead to the design of optimal vaccine, particularly to bacterial pathogens.
I'm sure you didn't understand much. Uh, you understand certain sentence here. We will go to our next slide and I'll try to explain. Remember, identify potential vaccine targets in a particular organ, not the whole organism, allowing for modeling of epitopes. Epitopes is a part of a gene. When you are producing not of a gene, the part of a gene against which antibodies will be protective. Now we'll go to the next slide. The one which was let's go with, okay, read the sentence now. Read it.
Neisseria meningitis serotype B causes quickly progressive meningitis with high mortality. Unlike the other strains of meningococcus, its capsular polysaccharide is silated like human glycoproteins, interfering with the ability to create a typical conjugate vaccine. Genomic sequencing of meningococcus serotype B led to the identification of 90 new surface antigens, of which about 30% bound to serum antibodies from immune patients. Subsequent murine models with selected antigens demonstrated effective protection, and ultimately these antigens contributed to development of the currently available meningococcus B subunit vaccine. A variation on this approach using computational analysis of the binding site of neutralizing antibodies to respiratory syncytial virus led to formulation of a recombinant immunogen that when combined with an adjuvant demonstrates protection in animal models.
Okay, now I'll try to tell you what is recombinant reverse vaccinology means. Okay, now what they now they can sequence the antigens of the because of, we have advanced very much in genetics. Okay, now previously they were finding in meningococcal serotype B there was no vaccination. We have a quadrivalent vaccine which is available here, which is A, C, W, and Y. I think W. I'm not remember. There was a quadrivalent vaccine which is available. But we don't have a vaccine against serotype B. Serotype B is very important pathogen, especially in UK. But they couldn't manufacture the vaccine because they couldn't produce antibody against it sequentially. Therefore, what they did genomic sequencing of identification of 90 new surface antigens were identified. Okay. And then what they did, therefore, 90, then they added the serum of patients who are immune to meningococcal serotype B, who have already had meningococcal serotype B. And these antibodies, they found out where they attached to. Selected antigen to more effective protection. Therefore, where these antibodies, out of the 90 new genome, they attach to 30 of these antigenic epitopes. And they use those, and some of them they use to make a subunit vaccine. Therefore, this is how reverse vaccinology means, that you are finding out first the number of antigens in the present, subunit, you do a genomic sequencing, you find out more antigens on the surface, you add antibodies from people who are protected and see which of these antigens attach, and then start using those antigens for producing this is the wall called the reverse vaccinology. This has been used in meningitis type B. Respiratory syncytial virus, they are desperate to find a vaccine. Why? Gopika, I am asking you this question. Respiratory syncytial virus. There's a common virus, isn't it? Why are you worried about producing a vaccine in that? It's one of the most important cause of mortality in very low birth weight babies. And nowadays, the monoclonal antibodies are only the answer to it. Anyway, I'll skip it now. Now, I think it is time. So far, we have gone into it, but there is in this also there are about 20 more slides. I don't think I will have time. We're coming late also. Therefore, next time we will go into the future vaccines, okay? And that will be dengue vaccine, malaria vaccine. Then we will try to discuss catch-up immunization. That all. And I'll first stop. Let me say I'll stop the recording first here. 1 minute hold and I don't have more control.